This is the Zero Downside podcast brought to you by moabtexas.com.
Well, welcome back everyone to another podcast episode with the Zero Downside. And today I still have Mike Mitchell and Dr. Wade McKenna. Today we're going to dive into the topic of bone marrow aspirate concentrate and how Dr. Wade McKenna actually developed an easy way to get to it and use it in our practice. And I'm excited to hear more about it and share it with everyone too.
I love that we just had Hannah use the marketing girl, right? So the business person use the appropriate science term, bone marrow aspirate concentrate. I love that because we work really hard in our clinic to not just call stuff stem cells because I hate that. But because technically, while the stem cells are in bone marrow, so are all the growth factors. Mm-hmm. You know, you're spinning down a platelet-rich concentrate from the patient's bone marrow, but that's where the stem cells are, right? And so you're concentrating the stem cells from your bone marrow to give you an autologous stem cell solution. But that's really the difference is technically in our clinic, we call it BMAC, right? All my notes, BMAC.
On the quote you get, see BMA.
Everything, it's BMA because bone marrow aspirate concentrate is the most scientifically appropriate term to describe that graft. Mm-hmm. And we try to use.
Can I get a high five for that?
Yeah, there we go.
Awesome.
I'm very proud. We know we really try hard to make sure that scientifically we're not using junk terms because it's popular socially. That we're trying to stay scientifically accurate and specific, and maintaining a scientifically accurate and specific conversation when you're competing with people that are calling everything stem cells, and we're injecting stem cells everywhere. It's way more difficult. My favorite, and I'm going to start this because I want to give a shout out to my grandma on this one. I'll never forget, and probably if you've seen me as a patient, you've already heard this story, because I'll never forget that I was probably, I don't know, young, and 8, 7, probably I was less than my daughter's age now. So Tess is who I talk to before every show because she tells me what my talking points need to be, because she's had to listen to all this, right? So my older daughters went through generation 1 on the catheter and all the drawings and all that. So Megan and Milan lived through the catheter, the development of the centrifuge stuff, and the original techniques. Tess has lived through, because she's 10, the development of the clinic, the delivery model, right? The science behind the aesthetic stuff that we do, which didn't exist when we were first using marrow for trauma patients, right? But I sat in my grandmother's lap on a swing, and she's rubbing my hair, and she says, "Sweetie, baby, I hate this for you. But if there's 2 ways to do something," she goes, "and you're just too smart." She goes, "You're just too smart for your own britches, and there's going to be a lot of things thrown at you in your life where there's going to be a temptation to take the easy way." And she goes, and she goes, "I want to tell you something, and it's a damn shame." She goes, "It really is. But there's 2 ways to do something a lot of times. One way is going to be really hard and take a lot of time and effort. And the other way is going to seem like it's such a nice shortcut and it's so easy." And she goes, "And I hate this for you. But almost always the right thing is the hard way." And she goes, "And I hate that because you're going to have lots of opportunities with your brain to take a lot of different shortcuts in life. Shortcuts never end up well." Yeah. And she goes, "And I hate it for you, but the hard way of doing something is almost always the right way." That all goes to say that we work really hard on doing it the right way, even if it takes more effort. It's a lot easier to say stem cell than it is to talk about bone marrow aspirate concentrate. And then you have to talk about the technology behind getting that. And what's the difference between raw bone marrow? Like there's still guys out there drawing bone marrow and just using raw bone marrow. Bone marrow is 97% whole blood. If you're not doing anything to concentrate it. Now, we can't manipulate cell count. The FDA is against anything more than minimal manipulation of the tissue. But it does allow us to concentrate it and make it better and get the components of the separation of that out to give you a better tailored result, right? Like you can't inject 60 cc's of marrow somewhere. So you want just the good part of it to put where the target is, right? The part that initiates, the sentinel cell, the cell that provokes the healing, the cell that communicates with the rest of you and put it where it goes.
Right.
We work really hard to use very specific terms. We don't talk about PRP as a stem cell. We don't talk about stem cells from your stem cells.
From your
we'll say
own
that
body.
when we're talking to people for a while because we're trying to give them that. But that's basically what it is. And that's what bone marrow aspirate concentrate. But in our clinic, we work really hard to maintain the very specific terminology on that. But it comes because of my background in the initiation and of the science of using marrow in medicine at all, right? I'm old.
Wow. Wow.
Well, it's just, we're going to use it wasn't even, let's look, it wasn't even a mesenchymal stem cell till 1995.
Yeah.
Right? Till Arnie Kaplan called it a mesenchymal stem cell, it wasn't a stem cell. So we're not talking about a science that goes back to like Hippocrates did not describe the stem cell. Mm-mm. He described a lot of cool stuff in medicine. But the science behind the biologics, and that's why one of the things that drive me crazy, and I realized this last week, is that anatomy and physiology, the science of the analysis of biologics, has been on a quantum path of doubling for the last 20 years. People that base what they're doing on their previous understanding of anatomy and physiology are not likely to be specific and correct about their treatment for their old knowledge base. The knowledge base of what we do in medicine needs to have advanced to the point where you understand what a cell secretes, how cells communicate, and what growth factors are, and what an exosome is, and the different types of stem cells, and the CD markers on different stem cells, and the fact that a hematopoietic stem cell is not wasted. There are a lot of terms in medicine that have changed dramatically over the last few years that if you don't understand modern physiology, you don't really get the use of the biologics because we weren't taught that in med school. Mm-hmm. Yeah. Cellular immunity, immune responses, what we were taught in med school never involved the stem cell. And since the stem cell mediates immunity, we probably, while we learned the basis of, by the limited understanding we had at the time, if your treatments are all based on that old knowledge base, what's the likelihood you're right? Mm-hmm. I mean, so, the lungs in a human, as we get older, become hematopoietic. Like we're not taught that the lungs make blood. If you look in a medical textbook and it says, your blood's made from the reason we draw marrow from where it would come from is because that's where the marrow comes from. That's where the blood's made. The
blood is actually produced there.
The lungs, pulmonary parenchyma, becomes hematopoietic as you get older. So when someone gets IV cells and they get stuck up in the pulmonary parenchyma, we used to think that was a really bad thing. That's one of the big clinics out of the country based their dosage on how much were they getting because getting hung up in the pulmonary parenchyma might have been bad. That was our thoughts 10 years ago.
Right.
Now we know that those cells getting hung up in the pulmonary parenchyma is probably one of the mechanisms of action because all your blood goes through your lungs, a lot. And that cell being triggered in the pulmonary parenchyma, seeing the disease blood come back, because like if you have heart failure, you don't have to get the cells to the heart. The cells have to get what they secrete to your heart, right? So them getting hung up at the pulmonary parenchyma is probably one of the therapeutic ways that they work. Now, if we're trying to use a local area of your body and we're not just talking about systemic failure or autoimmune dysfunction, then we want to put the cells where they go. Would a bunch of IV cells maybe make a difference in your ankle pain? Sure. If you have a big systemic overload of inflammatory load and we can take care of some of your lupus or RA, and if that's what they're doing, with when you're doing a systemic treatment for someone. But is that the best, most efficacious, least expensive, most tailored way to treat your ankle pain? No, it would be to address where in your ankle did you hurt? What ligaments did you tear? How much motion do you have? How much swelling do you have? And let's find out what's the most efficacious way to get that tissue to respond and heal. We got to get rid of your edema. We have to lower the inflammatory load. What's the best way of doing that? What's the best graft to do that? What's the other peptides? The stem cell secretes, and we haven't even talked about this, the stem cell secretes thousands and thousands of peptides and proteins. The exosome, which everyone now is That's another word I'm beginning
Equal
to hate.
stem cells,
I really loved that word in the beginning, right?
Yeah.
Loved the word exosome in the beginning because it was a
25
way of
billion,
getting rid of
50
the
billion.
25 other terms I used to use to describe what a stem cell secretes.
Yeah.
Vesicles of support, growth factors, the secretome. All these words we've used to talk about what a stem cell secretes, it's an exosome, right? Now, an exosome, the definition, the problem, and my nurse hates this, right? So Ashley.
Shout out Ashley.
Our nurse, yeah. So who's almost everyone that has had some.
One day we will get her in here.
We will have to have
One
her
day
in.
we will.
Absolutely.
Ashley is very much a no gray person.
Yeah.
She hates
White or black.
She hates leeway for things.
Yeah.
And so if Ashley was having to define what an exosome is, she would there would be death, there would be blood in the streets because the definition of exosome in real life is between about 0.35 nanometers in sporicity to about 1.4 nanometers in sporicity. And it's messenger RNA and growth factors and peptides and proteins secreted by the stem cell and packaged in fats. Lyophilized peptide protein or matrix of this amount of sporosity, that's an exosome. Now, how are exosomes defined by other clinics? Pieces and parts of spears sometimes.
Yes.
And certainly they've widened the margin. The way someone could say we have billions of exosomes is they're taking their exosomal measurements. Some of these clinics take it all the way up to 2.4 nanometers in sporicity. Are there some of those that are exosomes? Sure. If you take that down to less than 1.6, less than 1.4, is it a way higher percentage of those things that you measure that are exosomes? Yes. But if you want to cheat towards your side, just increase the definition of it, right? And because there's no one set, except it's like with PRP. The real definition of PRP is 5 times the growth factors of whole blood. Is that the way most people describe PRP? No.
Not at all.
So when we talk about stem cells, exosomes, then we're back to that. We use very specific terminology based on science to decide how to treat patients, right?
I would argue that a lot of the definitions we have come from just word of mouth, things that we've seen and heard, and location, PRP, where are you going to draw the PRP from? BMA or BMAC, where are you going to draw that from? And there's a lot of terminology out there. So let's go back to that, right? We've talked about the history. We've talked about those with more life experience than others, not old people, right? We're going to be polite. Say some people just have more practice at life than others, right? I do want to touch base on a couple things, right? Well, let's go back to the beginning, microfractures, right?
Yeah.
That moment where you poke a hole in the cartilage of the knee and you see bubbles come out, right? Moving into PRP, adipose tissue versus bone, the harvest itself, walk me through the timeline, right? From the first doctor that thought microfracture is the clear way to treat a professional athlete or the 80-year-old patient in his office because they came in with knee pain.
Right. Yeah. So what we know now is that microfracture does not generate hyaline cartilage. What we thought for a while, and the way there's a clinic in Colorado that got really famous for treating knees, was based on a microfracture because they published that there was cartilage, that it grew cartilage.
Right.
So the technique for microfracture was you put these, you drill out all the cartilage in that area that doesn't look great. And then you poke these giant holes in the bone. And when a little bit of bone marrow, these little fat droplets come from, while you're looking at it through the scope, while these fat droplets leak into the knee, that bone marrow is magic. That's the whole reason for a microfracture. The entire reason for microfracture surgery is to stimulate the bone so that marrow secretions initiate the healing. So the entire microfracture, the reason you're destroying a joint is to try to get the cartilage to heal better, because if you can activate the subchondral surface and the little bone marrow leaks into the joint, it's magic and it can help that cartilage grow and heal. Now, my thought as a intern, student, resident, and then fellow is you're watching and going to this much trouble and destroying the cartilage of someone's knee, drilling out large segmental defects.
Sounds painful. Like I just have a disgust look on my face right now.
We make people non-weight bearing for a month to 2 months. We would brace them initially, and they swell forever. And then a lot of times, because you've done such an aggressive chondroplasty and you've drilled all these holes in bone, the bone doesn't always heal. So we talk a little bit about avascular necrosis. Guess what? So what generated that little bit of marrow or microfracture surgery generates a non-hyaline. So the cartilage that it generates is more fibrocartilage. And so It's these big, disorganized, big, wet cells. So it looks good on MRI a little bit, and it can handle impact forces. It can't handle torsional stress. So it's not rebuilding someone's joint, right? So when you do a microfracture on someone, you're doing all this for a couple drops of marrow into the knee. My thought very early on was, if the magic of this is the marrow, and we're hoping for a couple drops from the condylar surface, which is not known as the best marrow in the world. The best marrow in the world is not your distal femur. We know that now specifically because we've done draws all over the body and validated where the best marrow would be as far as stem cell count. It's not the distal femur.
Right.
But we're going to all this work, doing a big surgery on someone, a couple drops of marrow in the knee. We're like, yes, we did a great microfracture surgery. All this cartilage is going to grow back.
Little teardrops
So my thought was, wow, what if we could harvest 60 cc's of that from where it would be better, so the pelvis, and then I could concentrate it down to recreate the physiologic volume. So everyone that's walking around has somewhere between 5-7 cc's of fluid on their knee when it's non-diseased. What we would want to do is recreate the physiologic volume of the knee with a healthier substrate. We want to treat the microenvironment so that cartilage can heal and grow, pain can go away, inflammation can be resolved, subchondral bone can get healthy, meniscal tissue can heal, and synovitis can go away. Right? That sounds like a really, really good goal, right?
So what's the answer?
Microfracture doesn't do that.
Well,
right?
a couple
But
drops from microfracture.
if I harvest marrow from you, concentrate all that down,
Right.
and now I stick that in your knee, did I have to go way backwards to stand a chance at going a little bit forward? No.
Fair.
The body gets a chance to take care of the inflammation the way it wants to. It wants a lot more cells in the knee to help it. It's just the knee's not kind of on the priority list a lot of times, right? So what happens is if we concentrate it, put it where it goes, you see true chondral defects and true chondral healing. Is that going to cure everything? No. Is it your body's best chance at at having any hope of generating articular joint space? Yes. If you're going to heal cartilage, if you're going to have more cartilage after a knee scope, you have to have bone marrow in the knee. And that's been published for a really long time. There's a study, it's like in 2008, where they did like 500 patients with arthroscopy, half of them with marrow, half of them without. They do total cartilaginous volume of the knee the day after the scope and then repeat it at 6 months. At 6 months, none of the knees that didn't have marrow had more cartilage in them, on average 10% less, because they were putting steroids in local on the knee and because of the manipulative stimulation of the knee and then wear after that. In the knees that had marrow put in the knee, on average, there's over 20% more cartilage in the joint. So day after the scope, go out 6 months. If you had marrow put in your joint, they all had none of them had less, right? So I was all disappointed because what I wanted of that study is I want the amount of cartilage in your knee to be directly proportional. So I wanted like an inverse graph. Like if you have 50% more cartilage, you have 50% less pain. That's not what happened. What happened is the pain score drops at about 7 to 11%. People continue to get up around that 24% plateau. But now looking back at that data, what I know now is you don't have to have all the cartilage in the world to not hurt. You just need a little bit more than when you started hurting. The articular cartilage in the joint is not the amount of it directly related to pain and wear. It protects the subchondral bone from beginning to collapse. It's like keep the foundation from collapsing, right?
So just even the smallest
just
improvement.
Just a little bit makes a big difference. And really, if you just lower the inflammatory load of the knee so it's not destroying everything, right? Most people still don't even understand. They talk about medial and lateral meniscus as completely separate entities, even orthopedic surgeons.
Yeah.
Well, my tear is medial, so I don't have any pain laterally. Okay, it's a big gasket, right? So the medial and lateral meniscus are intimately involved because as you rotate on one, there's a screw home mechanism with the knee, whereas you rotate on one, the medial meniscus has to tighten and engage, but the lateral meniscus has to relax and let that happen. So it's the meniscal unit of a knee. That's joint line pain. Not weight-bearing surface pain, not subchondral bony edema, not subchondral pain, not a lot of swelling pain. It's locking, catching, instability. It's a positive McMurray's exam, right? You put your finger there, you twist the knee in the right way. If it causes pain and click and pop, they probably have a meniscus tear. The guy that published that, Dr. McMurray, was just as specific at diagnosing tears as MRI. It was just as sensitive, excuse me. So his sensitivity on diagnosing meniscus tear is just as good as MRI on physical exam. The problem is the specificity, the location of the tear he couldn't figure out. Because a lateral tear and a medial tear on physical exam can feel the same. You can tell if the meniscus is functional, but you can't tell which side was torn. And I always thought that was a down step of, well, McMurray's just isn't that great a test. No, because the sensitivity of, is this a tear, is based on those symptoms of meniscal integrity. So McMurray's exam isn't to tell you if you have a medial tear or lateral tear. It's to tell you if you have dysfunction of the meniscal unit, right? An MRI gives you your targets for a scope. The physical exam decides what's causing your pain, right? A standing film, we use this, we tell people all the time, and we need to do this one day. We need to bring standing films and show people, go, this is what bone-on-bone arthritis really looks like.
So what are you looking for in the standing film?
Joint space, subchondral health.
Okay.
So cartilage doesn't show up, articular cartilage, meniscal cartilage doesn't show up on a standing film. So if you see space, you make the decide on a weight-bearing film, which standing films, the old guys got this right way before there was MRI, a lot. Not all the time. But a weight-bearing film means a lot, right? It's data. So for me, if there's subchondral collapse on a weight-bearing film and there's no joint space, I know, and that patient doesn't have locking, catching, giving way, I know their pain is coming from arthritis and loss of articular cartilage. So my goal becomes, how do I make the articular cartilage healthy? How do I protect the subchondral bone? If that standing film looks great and they're having an exorbitant amount of pain, I know it's not arthritis, right? It could be the inflammatory phases of arthritis, so synovitis or capsular pain or inflammatory disease or synovial plicas, but most likely if they have mechanical symptoms, it's meniscal or osteochondral loose bodies or symptomatic instabilities, ligamentous. There's plenty of things we still need the more traditional part of me for. I mean, I'm a fellowship trained trauma surgeon, right? Most of what we do from a surgical perspective is what I was really trained to do.
Right.
Like no one wants to think, and I use this analogy all the time because and you're going to probably hear this more than once, is that I didn't become an orthopedic trauma surgeon. I didn't finish my trauma fellowship until I was 34. I never took a year off. So 10 years from now, if you were me, you'd just be entering the job market. You would have been broke the whole time, right?
May explain a lot.
Yeah, right. So at 34, right, is the first time I have a real job. Now, do I want to look back and say that everything I've spent my 20s and half my 30s on doesn't mean anything? No. You almost have to approach it like a religion. Like you gave up so much for this training, it has to become that important to you, or it's not that's the rationalization for why I gave it up, is because it was so important. Hopefully that rationalization holds up and you get to be happy. But for the most part, there are times where you still need that side of me, right? Like I can't reconstruct your ACL if you have symptomatic instability with cells. Now, the use of cells can make it where your ACL reconstruction works. The failure rate of ACL reconstruction drops to almost 0, and the healing time drops less than in half on patients that have bone marrow aspirate concentrate injected the ACL graft at the time of their surgery compared to people that don't. That's really well published. But for the most part, this traditional part of me, that surgical part, there's a lot less people that need to be put into the cookie cutter flow chart of surgery than we think. And that standing film for me is one of those things, because you walk in and someone's bone on one side. I go, oh, Mrs. Jones, boy, that medial side looks terrible. Your left knee looks bad. And the patient will be, whoa, wait a minute. My left knee doesn't hurt.
So if you've got an MRI and you've got all your data on the patient, they come in, they've got an MRI done, whether it was one that was ordered through our clinic or not, would you still order a standing film, a weight-bearing film? And why?
A lot of times.
What are you going to see on a weight-bearing film as far as the spacing on both sides of the knee versus an MRI?
It gives me a way better view of a dynamic image, right? So for when you have an MRI, you're laying down, right? And so you can kind of fake a joint space sometimes, right? There are times where most MRIs are overread because they show little signal changes that really aren't clinically important. But a lot of MRIs, especially when it comes to chondral changes or reasons to discover why you're hurting, right? An MRI may not tell you why you're hurting. An MRI gives you a lot of pictures of degenerative changes and wear, but it doesn't necessarily tell you why you're hurt. And a standing film can help me at another data point to trying to give you a specific diagnosis and figure out what's the best treatment for it. Sometimes the best treatment for it is a total knee. I mean, look, I designed the instrumentation for the knee that we used to put the knee that we put in. But I designed the instrumentation for that like in 2008.
Yeah.
Right. I think total knee is important. I mean, total knee is the reason I became an orthopedic surgeon. Someday we'll have to tell a story, but I just remember thinking at 14 years old, oh my God, that changed this person's life. That's really important to me. I want to be able to do that someday. Like if everyone has to work to make a living, what a great way to make a living. And so for me, that was crucial. Now, do I feel that same way that total knee arthroplasty is still one of those really first line options for people? No, right? I don't think it's a first line option. Our requirements for a total knee is it hurts all the time, it keeps you awake at night, and nothing else helped.
Yeah.
And you're taking narcotics, right? We have a really cool process now to where, the problem with stem cells is it takes 3 to 6 months for you to be at the best you're going to get from that injection. Like chondrogenesis really it begins at around week 6. Most of the good part of healing happens between about week 6 to 8, all the way up to about week 16 to 20. Kind of what you have at about 6 months is what you have.
Yeah.
Right. From as far as cartilage growth from that shot. And people will say, yeah, but I continue to get better for years. Yeah, it's because we lowered the inflammatory load. We gave you a little bit more cartilage and you got in better shape and you have more muscle mass and you have more range of motion. You're pumping out.
Yeah.
That's why you continue to get better, right?
Yeah.
But the cell part at around 6 months, you're not continuing.
That's your magic mark that
you're
you look for
kind of not getting.
Can we circle back real quick before we start to lose our time on here? I would love for you to give a visual description of the bone marrow aspirate concentrate, catheter, and how it's way less damageable than.
So we have it right here.
We have right here, but those who can't see us on camera, give your best description.
So I think the description is, I was an oil field brat growing up in the middle of nowhere, Oklahoma.
You were?
Yeah. I spent a lot of time on mud, digging pits, throwing chain. Like there was the only
real country town doctor,
the only country kid. It was the only way to make a real money during the summers as a big kid that wasn't afraid. And so working for tongue trucks and mud services, but the process of fracking, right? So you're putting this, you put multiple holes in a tube so that you get flow back of fluid. So for marrow, what we wanted to do is create a system that liberates as much marrow as you can through a small amount of trauma as possible. And so the physics of fluid flow and the dynamics of low turbidity are what made me create the catheter. Because when you go to harvest marrow in a traumatic fashion, you get a lot of clotting. The cells go to the clot. And if you cause too much trauma at the time, when you do your cell counts, there's not a lot of cells in that. And so there's a lot of people out there that, after 80, there's no stem cells in your marrow anyway. That's not... They certainly can make that true. You can make it where there's almost no cells in a healthy marrow draw if you do it
depending
wrong.
on how you draw
it.
Yeah.
If you do it in a low turbid way. I mean, think of it this way, and people ask this all the time, and it's like, there are some things we do when we talk about knee pain, like cooling. It's like an ablation therapy on the nerves of a knee is almost like a party trick. Yeah. Like people stand up and walk out of the room and like, oh my God, my knee doesn't hurt anymore. The Marrow Aspirate draw kind of feels like a party trick to me too, right? Because we're drawing 60 cc's from a space that holds 10 or 12. Like, why am I drawing 60 cc's from it? And first of all, how? How do you draw more? Like it's like having $100 in your bank account and going and drawing 5,000. Like that's not possible. But it is.
It'd be nice.
It'd be great.
But it's essentially like the fracking.
But it's exactly like fracking. So what we're doing is we're causing retrograde blood flow. So when I create a decent enough space and a powerful enough draw, intraosseous, there isn't a lot of trauma. So you don't get a lot of platelet cell activation from in the bone. You get it from the outside of the bone. That's where a lot of pain comes from a bone marrow harvest, is from a subperiosteal hematoma. All bones covered in the periosteum. If you just poke a little hole in the periosteum, bone doesn't leak underneath it. You don't get a subperiosteal hematoma with the catheter. But what we're doing is we're causing blood to flow through the marrow, because anyone that's ever seen a picture of bone cracked open, the cancellous bone, it looks like Swiss cheese, right? But those cells are encrypted in there and they hide and they don't want to come out. And so when you're pulling 10 cc's out, that's a lot of the cells are in that first 10 cc's. But the biggest, baddest kid in the class didn't come out like that. Like he had to be coaxed and washed out. So when we pull 60 cc's, we're washing all those encrypted cells into my syringe because some of the biggest, baddest kids in the class could kind of hang on and try to stay where they were, right? So we're obtaining a higher volume to get a better cell count. And by then, putting it into a centrifuge that concentrates down the cells we want, we're able to deliver a more effective solution with way less trauma than most
Basically,
other procedures to get autologous cells.
All of the best
Yeah,
potent cells that are in the bone marrow.
Right, and I can do now. Can I do two draw? Can I do a draw from both sides? Absolutely, and get the cells. But if I just continue to draw marrow, like after 60 cc's, most of it's whole blood.
Yeah.
Right? So most of the cell, the reason that draw became 60 cc's is because we used to draw in 10 cc increments or take a cc off, send it to the lab and see where it was, right?
Yeah.
So what we found out is most of that is in the first 10 to 30 cc's. But even in that 50th cc, there's still some of the biggest, baddest kids in the class. And so what you want is anything north of 100 cc's is just whole blood. But now we can draw on the other side and get about the same cell count as I do on one side. And it takes about 3 to 4 weeks, and I could redraw from that side and get the same cell count as before. Now, if I draw from that same side 10 years from now, it's going to be lower. But if I draw from that same side within the same year, probably about the same cell count.
So do me a favor. Back before this show, we were in the green room. We like to kind of just float ideas out for shows. We try to keep it organically as possible. But you gave me an analogy of a table, and the traditional way of getting bone marrow out of a harvest, bone marrow aspirate concentrate out of a harvest was a jamshidi, right? Which if I could describe it best to anybody that's never seen one, it's literally a metal straw with a spike on the end of it. And it's a giant metal straw used to put to the back of whatever bone you have, and you're pulling on it physically with a syringe.
Well, but you have to put it in the bone first,
Yes.
right? And so there's two ways to get a jamshidi in the bone: brutane, right,
Oh my gosh.
or a mallet.
Yeah.
That's the only two ways. Yeah. So literally, there's a famous picture because it drives me a little crazy when Peyton Manning flew overseas to have a marrow draw that we developed here. With a jamshidi in his crest, and they have a claw hammer hitting it, and it was a picture out of ESPN.
No.
So the amount of trauma
impact
right.
a hole in the iliac crest. Now, what happens is you're fracturing that crest in a bad way. And so what happens is all those little it wasn't uncommon when we put dye and did this in pig pelvises. It wasn't uncommon to see dye 4 centimeters away from the poke hole because it's the bone cracks. So think of how painful it is if I'm driving a nail through your. So even with this table, if I pound on this table, every drink on a table shakes, right? So if you want to numb up for that draw, how do you numb up the whole table? There's not a way to do that. So even if I numb up the spot, if I impact a nail through it, which is literally what it is, you're impacting a nail through it and then putting a syringe in harvesting. When you do that, it's really, really painful.
It sounds
That's where the history is going. And it can hurt for months after that. Because when you leak marrow up underneath the periosteum, it'll show up on MRI as a subperiosteal hematoma for almost a year. It can take a year for you to get rid of that.
Oh my gosh.
Right?
And yeah, my favorite thing is always telling patients it's one stitch.
Yeah.
It's one single
little
stitch.
poke hole, right?
You can clip it out at home 12 days later.
Yeah.
It is
and most people, so when Ash, the nurse that we're going to have to.
I know, Ashley needs to be here.
When the nurse takes that stitch out, most people forgot about it.
Yeah.
So especially if I do that at the time of a rotator cuff or a knee scope, because every rotator cuff and knee scope that I've done for the last 15 years, I use marrow on because it heals better.
And also clear
Most
this
people
too,
forgot
because
about that
people do ask, like I've had a patient ask before, so is there going to be a permanent hole in my, please explain it just for those who might have that question.
Quick, right? So that active bone fills itself in very quickly. And again, because I'm very much a historian in many subjects, but especially medicine, we understand how to not just you're not poking some giant hole in a bone that's going to leak and hurt forever. What we're doing is, so I literally mobilize the soft tissue of a bone. So if I'm going to drill a hole in my forearm and I just drill it right through that into that bone, that skin is going to be adherent. I'm going to have leakage. I'm going to get a lot of bruised tissue. And you can get what's called a synovial tract, When I go to pull that out of bone, it will literally track and leak through that hole and communicate. So the old guys that would do iron injections in your glute would take and called a Z-track. They would move the tissue over, then inject the iron and then let go. And so now your body kind of forms a fat Band-Aid to kind of keep it where they put it.
Okay.
Because I studied a lot of old techniques, what I know is when I go to draw that marrow, I mobilize the soft tissue. I poke my poke hole here. So now the poke hole in your skin and the poke hole in that bone are way apart from each other. Because when I let go, now you kind of have a fat tissue Band-Aid. So you don't get a lot of leakage from that. You don't get a lot of continued bruising. And that bone's going to fill in and heal. Bone is one of the only tissues in the human body that heals with the same kind of tissue. Right?
The more you know.
Now it cannot heal. You can get a non-union of a fracture. But when you get a fracture that heals, it's not cartilage, it's not tendon, it's not fat, it's not subcutaneous tissue, it's not vascular, it's bone, right? So tendon doesn't always heal with tendon. It heals with scar. Some of the scar's in. But subcutaneous tissue may not heal at all, right? Hair, scar, but bone usually heals with bone. So when I provoke a healing response and now I'm drawing marrow through that doesn't leak. You don't get a lot of bruising. And we don't draw from that same hole because it heals very, very quickly. Right?
Thank you for clearing that up.
Yeah.
I appreciate that. I think a lot of what you do centers around the thought process and the passion and the intellectual property put into something as simple as a catheter. Right. Just the means to draw it out of the patient. If it was still really hard to get bone marrow cells, we would not have this many applications for autologous marrow. Right? We're taking autologous marrow for people on an elective basis to help them grow hair, to help your skin tighten up, sexual wellness, chronic tendonitis, athletes that'll come after a season just to be tuned up. Both my ankles hurt, both my shoulders hurt. I don't have a tear anywhere, but I'm really inflamed. Because marrow is not the most invasive process in the world to get anymore, we made it to where you don't have to have cancer to make a marrow draw worth it. Yeah. If it was still a really morbid process that hurt a lot, it wouldn't be worth getting unless you were really, really sick or really, really hurt, or unless everything else didn't work. It'd be like the way I think of a total knee. I think of a total knee as when nothing else helped. That's what I would think of bone marrow for if we didn't make it to where it was so easy to get a good quality graft. So in talking about that, we've discussed, hey, this is the microfracture. Was that of the condyle in the knee or the tibial plateau in the knee? I've seen bone marrow collected from a heel, right? The calcaneus. I've seen quote unquote bone marrow draws. And if you're watching on video, this will be fun. I've seen bone marrow taken from adipose fatty tissue around someone's abdomen, right? I've seen it from everywhere, but you mentioned pelvis, right? You've talked about the hip and the pelvis. And in the training, in the fellowship training as a trauma surgeon, and all these different exposures, what makes you want to draw it from that portion of the body, right? When you mentioned pelvis, me as a patient, I'm thinking, I'd rather you take it from my forearm like you showed earlier than my pelvis.
Yeah, so here's the good news, right? I, as a trauma surgeon, you become, and especially in orthopedics, you become the pelvis acetabulum trauma guys because people die, right? So if someone has a splay pelvis, we had the reason you do a fellowship in that, and not during your regular residency do you do many of these, is you want to put a pelvic frame on. So it means you have these 3 big pins you put in someone's pelvis, and they're 6.5 millimeter pins. Like it's a big screw, right? It's bigger than this pin, right? And you're putting that in your crest because I have to put these 3 big pins in here to close your pelvis and then put a bar across it. So you walk around with the pelvis external fixator. I can put a pelvis external fixator on with my hands, touch, and then verify placement with C-arm, because I had to be able to do that to save your life. Because if you have pelvic splay, you're dying, you're bleeding to death. If I close the pelvis, it stops enough of the blood loss where you stand a chance of being resuscitated. So the whole science of between a pelvis external fixator, I knew really well that the anterior pelvis has a really good space that's really safe, that's easy to get to, because I put pelvic frames on people as a trauma fellow. So the posterior superior iliac crest is where most bone marrow harvests are done that hurt forever, because they're going to the one area that most people feel comfortable in, because that's all they've been exposed to, of drawing marrow. In orthopedic trauma, I'm really comfortable with the anterior anatomy of the pelvis. And because I'm putting giant pins in an external fixator on. So putting this in the anterior crest compared to 3 of these on both sides seemed kind of easy.
For those
right.
just listening, what is the full length of this thing, you think?
The effective length of the inner diameter of the catheter is about 1.5 centimeters.
Okay.
It's a 15 gauge catheter basically. But this is not a drill, right? A drill would stimulate flow back and forth. It's a diamond tipped catheter. So we're placing a hole to place a catheter in its spot that has radialized cuts. You know the beer commercial where they talk about the swirl of the turbidity in the can? That's what this is based on, right? Is limiting turbidity of flow. And so the reason for the angle of those holes and the reason they're offset is because I had to study a lot of physics of flow to be able to design that, right? Because I don't want just bone marrow coming from the tip. I want it coming in a low turbid way, and I want to get the biggest draw area, the frac part that we can get.
Incredible.
Any science that revolves around fracking and beer, I'm
You got our attention.
Years before that, when I was going through the flow dynamics of that, I'm literally watching a commercial years later, and I see them talk about the beer can being designed to help the beer have less flow, and I'm just like, wow, like a physicist designing a beer can. I'm totally in. Right? But that's literally the physics between fluid dynamics and flow is what we designed the catheter on. So we made it where you can get a good quality. Look, basically what all this comes, you guys laugh at me all the time because I try to simplify stuff, but I still use a million words to do it.
You do. Okay, that's perfect. Yeah.
But with bone marrow catheter, it was about ease and quality. Yeah. If you don't have quality allograft, there's no reason to take it. If it's not easy, you have to be dying to use it. But if you can make it where it's easy to draw, it's less morbid, and then you can still get a quality graft, then that's still the basis of most biologic healing is that cell.
Well, ladies and gentlemen, that was everything on bone marrow aspirate concentrate from Dr. McKenna and Michael. And I think that's going to be a wrap for this episode.